everybody, welcome. Thanks for joining us this afternoon. I'm Jody DeMorgan from ICSI.
And I'm Audrey Hansen from ICSI.
And we're really excited to have you join us for this webinar with DHS to learn more about the Opioid Prescriber Reports. So we're going to turn it over to our DHS colleagues to tell you a little bit more about the program, and then our speaker, Dr. Charlie Resnikoff, will take it from there.
Can you all hear me? Yes, hi.
Yes.
Great. Well, good afternoon, everyone, and I echo Jody's comments. Thank you so much for joining us for this call today. My name is Sarah Rinn, and I am in the Healthcare Administration at DHS, and I am joined by my colleagues Jessica Hultgren and David Kelly, and we all work on the Opioid Prescribing Improvement Program. Just a quick overview of the project. This project began in 2015 with the Minnesota legislature. They authorized DHS to form an expert advisory body of physicians and pharmacists and consumers to help the state develop opioid prescribing guidelines. And from those guidelines, we developed measures of individual provider-level opioid prescribing practices. And those 7 measures, in turn, support the opioid prescribing reports that we released for the first time last summer. And we are getting ready to release another round of reports, so this webinar is incredibly timely. And then looking into the future in 2020, these opioid prescribing reports will help support a quality improvement project at DHS. And that is just starting to be defined right now with input from the opioid prescribing work group and the medical community on a much broader scale. So I have the privilege today of introducing Dr. Charlie Resnikoff. Dr. Resnikoff is an addiction medicine and internal medicine doc at Hennepin Health. I think he's pretty well known to many on this topic. Dr. Resnikoff is a member of the opioid prescribing work group and also collaborates with ICSI on many things, but namely our opioid prescribing work. Dr. Resnikoff is a true champion of this work, and we are so appreciative of him taking the time today to present on this phone call. And so with that, I'm going to turn it over to Charlie.
Okay, can you hear me? You can hear me? Is that a yes? Okay, cool. I will dive right in because there's always lots to talk about. I'm excited to give this talk. Hopefully it's helpful. If you want to correspond with me individually, I'm sure everybody involved would be happy to take emails with follow-up questions if you want to ask something offline. So I don't know, think about who would be best equipped to answer the question. And I'm sure I speak for everyone saying reach out if you have a question after this is done, if the question is not answered. I don't have any disclosures that are relevant to this talk or really any financial disclosures at all. I am a member of the Opioid Prescribing Work Group, and I'm a co-leader of the ICSI Minnesota Health Collaborative Opioid Stewardship Committee, and also I contributed to the recent ICSI pain guideline and perioperative guideline. So I've done a lot of work with both. So I'm a vested party in both with both organizations. I'm going to try to say what this opioid report is. I'm going to give general advice on interpreting and acting on it. We'll review actual reports and then hopefully some time for questions. So as you may know, in September 2019, a first report came out, and it was really an FYI only. We're kicking the dust off. It's informational for you, and it's also informational for DHS who are trying to learn and have the process get better. And to that extent, soon, in early 2019, really, there'll be another report. And this, again, will be only to improve the process, to give you a good sense of your own prescribing numbers, to make sure everything's good on your end, you understand it, and to make sure everything's good on our end, that our process is working. We're reaching providers are understanding the material, that sort of thing. And then in late 2020, and maybe November or December of 2020, the first live report will go out. And this will have the QI thresholds, quality improvement thresholds, and I'll talk about what that means. But it's sort of like, this is the real deal. And this is going to be really a year from now that we'll have the go live report. And then it should be annual reports thereafter. Who will receive these reports? Nurse practitioners and physician's assistants. And in a prior talk, actually, I got a comment that the nomenclature for nurse practitioners is more variable than just nurse practitioner. So anyone with a nursing license who's managing patients, including prescribing opioids. So nurse practitioners, physician's assistants, physicians, dentists, and residents, if that medical resident, that trainee is prescribing from their own DEA license, which is sometimes the case. Anyone prescribing an opioid, in other words. The report contains data on 7 measures for that individual provider. The index opioid prescribing rate, in other words, how frequently do you initiate opioids? That's the index opioid prescribing rate, that's measure 1. Measure 2 is the index opioid prescribing dose. When you initiate opioids, do you tend to do it at a high dose or not? I'm going to get more details on all of these in a minute. Measure 3 is a little complex to explain. It's the rate of prescribing over 700 cumulative morphine equivalents in a new patient. In other words, if you take a patient who's newly on opioids, how often are they continued past 700 morphine equivalents, which means they're sort of flirting with becoming a chronic pain, chronic opioid patient. So it's that middle zone where they're no longer in acute pain, but they're not yet a chronic pain patient. What is this provider's rate of progressing people through that middle zone towards chronic opioid use for pain? 4 is how many chronic opioid use for pain patients do you have? How many chronic pain patients on opioids do you have? What's your rate of chronic opioid patients? 5 is how many of those chronic opioid patients, and we call them COAT patients, C-O-A-T patients. They're not just chronic pain patients. They're chronic pain patients on an opioid for pain. So how many of your COAT patients are on high dose COAT? 6 is how many of your COAT patients are also on a benzodiazepine, which is a worrisome combination of drugs. And 7, how many of your COAT patients are receiving prescriptions from many providers, which can be a sign of fractured care or it could be a concerning sign. So the way to think about these measures is that measure 1, 2, and 3 have the intent of decreasing the rate of new chronic pain patients, new COAT patients happening. We're trying to stop new patients who are on opioids every single day. So measures 1, 2, and 3 are to try to stop that from happening, unless it needs to happen. Measures 4, 5, 6, and 7 are sort of ways of understanding how many chronic pain patients is this provider seeing and how many of them are high-risk chronic pain patients. So 1, 2, and 3 stops the chronic pain patient from starting opioids, and 4, 5, and 6, and 7 tells the provider how much high-risk chronic pain patients they have in their practice. Okay, the measures in red are ones to which a quality improvement project could be attached, depending on the individual provider's practice. And we have deliberately exempted 4 from a quality improvement project. If you think about it, 1, 2, and 3 is trying to lower the rate of 4. If we do measures 1, 2, and 3 well, we're going to have fewer people entering category 4, what's captured by measure 4. And 5 and 6, our quality improvement is to try to encourage providers to maybe carefully move people downward towards measure 4, right? If you're in measure 4, you're on chronic opioids alone, there's no QI, there's no quality improvement project assigned there. But 5 and 6, you have a high-risk chronic pain patient. We want to sort of gently nudge patients, providers and patients, towards getting more people into category 4. So we wanted to carve out category 4 as sort of a safe space for patients to be, meaning that there's no quality improvement attached. So this is what the report looks like. And a couple important things to note on this report. Your specialty, take note that your specialty is correct on your report. Obviously, your name and your address, that's important to get right on the report, but the specialty is really important. The NPI number's up there, and also the contact information for DHS is on the report as well. And then if you look at the report, the blue bar, there's those 7 measures on the report. The blue bars represent this individual provider's performance, if you want to use that term. And the yellow or orange bar, I guess it's an orange bar, measures other providers in that same specialty. And that orange bar is mainly there for comparison, for your information to see how close you are to your colleagues within your own specialty. The vertical red lines over on the right represent the quality improvement threshold. And crossing that line a year from now will result in some form of a quality improvement work, which I'll try to briefly describe in a second. So that's kind of how you navigate this. Other important things to navigate, I'll get to this later. The numerator and the denominators are present for each measure. The denominator for measure 1 is basically the total number of Medicaid patients you saw in that time period. You probably in that 12-month period. So that's a kind of an interesting measure to look at. That's the number of Medicaid patients, pain or no pain. That denominator for measure 1 is how many Medicaid patients you saw. And then each denominator and numerator is defined with a separate document. And if you want to get into the details on that, DHS can provide you the specific technical definitions of each numerator and denominator. So what if you didn't get your report? And this happens a lot, actually. There's a variety of reasons for this. Initially, we tried to distribute the reports through minutes, and that was a little cumbersome. If you happen to register through a minutes mailbox in time, your report is there. If you didn't set up a minutes mailbox, the report should have been mailed to you like in an envelope, an actual piece of mail. And if you didn't receive that, well, you know, in the case of my institution, they all came through the same mail room, and one of our executives actually noticed the same envelope from DHS is going to all of our providers. So grab them and organize them. So you might check with your institution because they saw all these travel through the mailroom, or make sure that your Medicaid mailing address is up to date. And there's a variety of ways to do that. And DHS has given a form to help you update your mailing address to make sure it goes to the right address. And then finally, if you just can't find your report, you can't get it, it was lost, someone said they didn't realize it was important and they shredded it or they threw it away, you can email DHS and ask for an electronic copy of your report. What if your specialty is not correct when you look at your report? This is very important if you're in a surgical specialty and it's not listed as such, because it affects some of the quality improvement measures. But besides that, your specialty is mainly doesn't affect, the only thing it affects is those orange bars, which is your comparison to your colleagues. So, and that's helpful. You must get your specialty correct if you're in a surgical subspecialty. But if you're not in a surgical subspecialty and they get the specialty wrong, it's debatable. It's worth getting it correct, but it's less immediately important. And you can correct your subspecialty through, basically through the NPI database. And there's a website to go there to correct the NPI database. It is worth noting that physician's assistants and nurse practitioners have a really not helpful specialty database with NPI, and therefore many nurse practitioners or physician's assistants work with surgical patients. But it's impossible for them to, through the NPI database, designate that they're, in essence, a surgical nurse practitioner, and therefore nurse practitioners and physician's assistants really ought to let DHS know if they're specifically working with a surgical patient population, specifically providing post-operative opioids for pain. They're going to want to let DHS know that, and DHS can give you more information on how to get that done. They're developing a process. Many patients are excluded from this report. For example, patients with a recent cancer diagnosis or recently receiving cancer treatment are excluded. patients in hospice care at the end of their life are excluded. Patients receiving buprenorphine are excluded. Many or most of the buprenorphine patients are receiving buprenorphine for opioid use disorder, and this report is not about, this report is about opioids for pain. This is not about opioids for opioid use disorder or other rarer surgical procedure, intraoperative procedures. So opioid use disorder treatments are exempted from this report, and that also includes methadone given from a licensed methadone clinic. But also inpatient treatment of pain is exempted from this report, and procedural like intraoperative sedation or opioids given in the intensive care unit when someone's intubated. Those forms of opioids this is about opioids for pain from an outpatient pharmacy. That's basically what this is about. Not for cancer pain and not for hospice pain. So if you go to measure one is the numerator is the number of patients that this provider has started opioids on, and the patient has to have been opioid naive prior to starting opioids. So it's index cases of opioid prescription. And that's the numerator. And the denominator is the total number of Medicaid patients you see in that time period. So for the last 12 months, for considering all the Medicaid patients you've cared for, how many of them were opioid naive until you started opioids? And the quality improvement threshold for this is 8%. And almost all providers are very safely below that 8% threshold, such as most primary care providers, even most emergency providers. We set these thresholds knowing the breakdown of providers, at least with the 2016 data, and opioid prescribing has decreased since then. So we set this threshold with a pretty wide margin so that most providers would not be affected by it. But if you initiate opioids for greater than 8% of your patients in that time period, you would be over threshold. Surgical subspecialties are exempted from measure one because it's a given that everyone they see may have undergone surgery, so their frequency of initiating opioids is going to be very high by nature of their work. And this is more of an explanation of what I just sort of talked you through. Measure two is when you initiate opioids, again, still for that opioid naive patient, when you initiate opioids, are you doing so at a high dose? And by a high dose, we don't mean the daily dose. We don't mean the dose in the pill. We mean the total amount of opioids that is put in that very first prescription over the course of the entire bottle, the entire prescription. How much opioids is in that first bottle? And what we're hoping for with a non-surgical specialty is that 50% or more of the time, the total dose of opioids is 100 morphine equivalents, 100 MME, or the equivalent to 100 milligrams of morphine. And I'll give you some examples of that in a second. If you're a surgical subspecialty, because your patients by definition have gone to surgery or are likely to have gone to surgery, our threshold is 200 morphine equivalents. And I'll give you examples on what those numbers mean. And that's only 50% of the time. 49%, 50.1% of the time, you need to be under that threshold. 49.9% of the time, you can prescribe whatever dose you deem appropriate. So DHS recognizes there are instances where high dose initial opioid prescription is warranted. And we can talk about some of those instances. And DHS wants to create space for you to appropriately treat pain when high dose opioids are warranted right off the bat. But we don't want it every time. We want the majority of the time for that dose of opioids to be safely under 100 morphine equivalents in the bottle, and for surgical subspecialties under 200 morphine equivalents. So here's a description of that. 100 morphine equivalents is basically equal to 20 Vicodin, to use the trade name. of 5 milligram hydrocodone tablets that's typically what we mean when we say Vicodin, hydrocodone acetaminophen, but it's 5 milligrams of hydrocodone, or 13 tablets of 5 milligram oxycodone. So 13 Percocet or 20 Vicodin. Those are the common prescriptions we give out, and those would be equal to 100 morphine equivalents a day. So that in our system, that's a little bit of a challenge in that many of our providers want a single number for either Vicodin or Percocet, and they say, I just keep it one number. Well, if you got to keep it one number, we would suggest you keep that number 13, because that'll get you under the 100 morphine equivalents for either medication. But more importantly, recognize that oxycodone is stronger than hydrocodone. So the same number of tablets, you actually are giving more opioid when you give oxycodone. The moral of the story for the non-surgical specialties to try to keep the total dose of 100 morphine equivalents most of the time be under 100 morphine equivalents, which means under that prescription. And if you give morphine or Dilaudid or Tramadol, you can talk to your pharmacist, or you can talk to DHS about their conversions and know what for whatever opioid you like to give, what the correct dose would be to be under this threshold. So it's worth doing some research if you prescribe one of those other medications. Measure 3 is a little bit complicated. The concept with Measure 3 is when someone starts on opioids and they have acute pain, very often we don't think about chronic pain until 90 days. Well, 90 days is way too long. You can't wait until 90 days to think about chronic pain, because what we now know, both with internal data and with national publications from the CDC, is chronic ongoing opioid use is established way before 90 days. Before 45 days, really, it's already 45 days and 90 days are similar, and we want to intervene even before that. So can we intervene at some point where they're out of what should be the acute pain phase, but they're not yet a chronic pain patient? And we want to intervene early to try to de-escalate opioids, because so often in medical care we just refill, and then whoops, we got a problem. And we want to stop those automatic refills a little earlier. So what we did is we picked a number that was actually highlighted by the CDC in a publication a few years ago, 700 morphine equivalents. And we don't care about whether this was one provider or 3 providers who gave these opioids. And we don't care whether it was 1 bottle of opioids or 3 bottles of opioids. What we care about is in that treatment episode, regardless of how many different providers saw the patient and how many different bottles they got, when they have reached a cumulative dose of 700 morphine equivalents, the probability of them going on to becoming a chronic pain patient on chronic opioids is too high. And we want to pick that as our point, where most patients should be de-escalated from opioids before they reach 700 morphine equivalents. And what we would like is that 85% of patients who are initiated on opioids are de-escalated before they reach that 700 morphine equivalent cumulative exposure. 700 morphine equivalents equals 140 Vicodin, if you want a trade name. If I realize Vicodin may come in different strengths, but the traditional Vicodin is 5 milligrams of hydrocodone. So 140 Vicodin, and it's something like just over 100 of the Percocets. You have to, and this could be from any provider. So if we're talking about Vicodin, it doesn't matter who prescribed the first 139 Vicodin. If you're the provider to prescribe the 140th Vicodin, this case counts towards your numerator, towards your Measure 3. So what it really does is it creates the onus on all of us to intervene early. 1, intervene early. 2, before you give any continuation or refill of opioids, think about, should I check the prescription monitoring program? Should I see how many prescriptions they've gotten? And how far along towards a chronic pain patient have they developed? And again, 85% should be de-escalated before 700 morphine equivalents, but we recognize some patients have serious conditions that are ongoing, requiring ongoing opioids. And we recognize that, so we don't want 100% de-escalated, but we just want the vast majority to be de-escalated. And I think most people would say that an acute pain episode is almost always resolved before 140 Vicodin, which is 1 month of taking Vicodin every day. And so that's measure 3. Measure 4 just gives the provider a sense of how many chronic pain patients on opioids they have. And there's no QI attached to measure 4. This is how many patients am I prescribing chronic opioids to? And it's important for you to understand that we don't mean you've prescribed daily opioids for an entire year for this individual. It's really shorter duration of opioid prescriptions, and you can look at the numerator and the denominator, those definitions, so you understand exactly how to interpret this. I think it's, well, we're going to ask Dave, I get these mixed up. We're going to ask Dave Kelly at the end of this to define what gets you into the numerator of measure 4. That's an important definition. I can't remember if it's 1 month or 2 months, but it means you're prescribing ongoing opioids, daily opioids to someone. And so this is your measure of how many people in your practice do that. It doesn't mean you're the only person giving them opioids every day of the year. The number's higher than that. Yeah, so here it is. The numerator is 60 days. So if you've given 60 consecutive days of opioids to someone, they're in your numerator. So 2 months of continuous opioids gets them in this measure. That's the answer. Measure 5 is of the people you're prescribing chronic opioids to, how many are on high-dose opioids? And for high-dose opioids, we use the CDC guideline threshold, 90 morphine equivalents a day. There's nothing magical about that number other than the CDC chose it, but it's a reasonable number and it's become sort of the benchmark. So 90 morphine equivalents a day. We are hoping that of your chronic pain population, 90% of them are on less than that. And only 10% of your chronic pain population are on that high-dose opioids. And again, as I mentioned earlier, we trialed all these metrics using 2016 data, so we basically know the breakdown, and we know that most providers are going to be okay with this threshold. But measure 5 is a really important threshold, because if you exceed that threshold, if you have more than 10% of your chronic pain patients on high-dose opioids, those are very vulnerable people. They are more likely to have mental health comorbidities, they're more likely to have undiagnosed addictions, and they're more likely to die from their opioids or from other causes, such as suicide. So this is a very high-risk group, and we really want you to know that you've got a high proportion of these high-risk patients that require special care. And so here are the metrics for that. Measure 6 is of your chronic opioid patients, how many are also receiving a benzodiazepine? And as I'm sure you know, the mix of opioids and benzos is incredibly dangerous. The mortality rates, adding a benzo to an opioid increases mortality in a multiplicative way. It's not additive, it's multiplicative. And so it's really a dangerous combination of medications. And the state has a very high degree of interest in taking care of these patients because they are at risk of death and other serious adverse events. What we want here again is of your COAT patients, your chronic pain patients on chronic opioid therapy, 90% are not on a benzo, and only 10% are on a benzo. 10% or less are on a benzo, hopefully less. And for this, we are only using chronic pain patients on 50 morphine equivalents a day, and there are technical reasons for that. But if you're under 50 morphine equivalents a day of opioids, you don't count towards the numerator on this measure. And there's some implications of that, which is that for patients that insist that benzos, or even in your clinical judgment, if benzos are appropriate for this person on chronic opioids, you could work carefully to get them to a dose less than 50 morphine equivalents. And that might be one solution. Or you could carve out, this is one of these rare instances where I'm going to monitor carefully as the patient's on opioids and benzos. The one challenging part of this measure is that it doesn't matter who prescribed the benzos. By law, this whole project that I'm talking about is focused on opioids. This is not a benzodiazepine project, and that's written into the law. So we can't really monitor or give feedback to the benzo prescriber. We're giving feedback to the opioid prescriber. And if you're the opioid prescriber, the benzo in the patient's body doesn't care who prescribed it, if you know what I'm saying. That person, the risk is, in fact, the risk is arguably greater if a separate provider prescribed the benzo than if you, the single provider, prescribed both opioids and benzos. We know in our state that approximately half of these co-prescriptions are the same provider. A lot of this is all under the same house, but there are instances where your chronic pain patient goes to another provider and you're not even aware of it until after it's happened. So there's some challenges inherent to this Measure 6 where there are multiple prescribers on board, and it really forces the provider to have good communication with the patient and with your colleagues that are potentially prescribing benzos. And the minimum amount of benzos to get you into this numerator is 7 days or more benzos. So Measure 6 is a challenging one, but it's also a very important one. Measure 7, there's no quality improvement threshold attached to it. It's mostly a FYI, and it is designed to let the provider know if a high proportion of their patients are getting opioid prescriptions from multiple sources. And that's just important information for the provider to know that whatever it is about my practice, my patients to whom I'm prescribing chronic opioids are also getting opioids from many other people. And so that may be inherent, that may be a shared practice, and that may be normal, expected, or that may come as a surprise to the provider that many of their patients are shopping around for opioids elsewhere. But it's an information, it's a measure for information only. And so now I'm going to just briefly talk about quality improvement projects. I mentioned the thresholds. Many providers, I think, right, many providers, let's say a substantial proportion of providers in the double digits percentile, not the majority of providers, but many providers are going to have a quality improvement project. And I think, I was talking to the folks at DHS about this. The tendency for docs and nurse practitioners and physician's assistants is to get a report card, see it as a grade, and want to get a better score on the grade. And to see quality improvement as I must have poor quality, or to see quality improvement as a punishment to be avoided. And we are really trying to avoid that impression in the Medicaid providers. What we are seeing quality improvement is, especially for the chronic pain patients, you have a high-risk group of patients, and the state just wants to make sure you're doing everything you need to do to take good care of them. And that's kind of my interpretation of it. What we don't want with the quality improvement thresholds is people to see it as a number to try to, how quickly can I make this better? Because you got to do it in a patient-friendly way. So we're working on that as a group to try to get these quality improvements framed correctly for providers so it's constructive towards the patients, the system, the providers, and make it as much of a win-win as possible. We're in the process of defining them. They're open meetings to the public, so I think the next meeting is this Thursday, Thursday afternoon. So if you wanted to attend, you could contact DHS about that. These quality improvement projects go live at the end of 2020. And if you exceed a threshold and need to perform this quality improvement homework, your health system will be notified. Otherwise, this is a totally private individual report for you. So no one sees your report unless you're over a QI project. Then your health system or your employer may be notified. It is likely that your health system is going to be able to offset a lot of the QI work. I mean, the state just wants to know that you are aware of your own opioid practice and you've done all your appropriate due diligence to take good care of these patients. And many systems already have this work underway and are already really doing a good job at this work. Actually, ICSI is involved with many systems to improve the care they're giving to opioids. So a lot of this QI work is being done already. In other words, it's not going to be a torturous process, and you're going to be able to look to your institution to help you often. It's going to be about things like adopting basic screening to assure that you get all the basic screening that you need to get for these patients who are at risk of bad outcomes. And also that you really understand your own data and you're able to track and look at your own data so you know which patients are on chronic opioids, which of them didn't show up to clinic, which of them haven't gotten a urine drug screen recently, whatever. You should have that data, access to that data, and systems are already kicking into gear to provide their own providers with that data. And then finally, to improve your care. And that's what we might call adaptive change. And we're going to be really careful in how we ask you to adapt your care, because we don't want to create unintended consequences. And we have, we're measuring your metrics, but we're not in the room with you with your individual patients. And so we are going to have some adaptive changes, how you can, when you give referrals for addiction consultation or mental health consultation, and even when you initiate opioids or how you choose to prescribe opioids or benzos, for example. But we're going to be very cautious in how we ask you to adapt your practice in that way. And there are going to be exceptions to QI, and the exceptions I like to talk about, I'm in a trauma center, and we have incredible polytrauma. We have severe burns. We have, of course, we have a cancer clinic. Cancer is exempted, but the cancer clinic takes care of a lot of patients with sickle cell disease. So we have some really high-risk patients that no one would argue should be on opioids, and that's not even a debatable point. And we have certain providers that are highly specialized in giving care to burn patients. And how does a burn surgeon navigate this system? And so there are going to be many instances in both tertiary referral centers like Hennepin and also in rural clinics where maybe in your rural practice, all of your colleagues have asked you to be the pain provider for the practice. I'm just making that up. But there may be some instances in rural practices where you're not a subspecialty trained provider and yet you've taken on subspecialty level care. There's going to be a process by which for you to explain your special circumstances. But I want to warn people that every provider has special circumstances, and every provider can tell a story about their own circumstance and how that leads them to exceed this QI threshold. Not every provider is going to get an exception. So think about, do you have a truly unique circumstance and a truly unique patient population and job description requiring high-dose opioid or high-frequency opioid prescribing? That may put you in an exception category. There's also going to be a low volume threshold, and we'll talk more about that in a second. I mentioned there's a second round of reports coming soon, and the second round of reports is, again, just to give you information. So some patient care considerations. This is mostly stuff I've directed at my own colleagues in my own institution, so I'm sharing with you what I tell them. If it could harm a patient, do not change an opioid prescription. Do not change an opioid prescription to satisfy our measures if it's going to harm a patient. And specifically, don't abruptly discontinue or abruptly lower an opioid dose. That's going to the patient's going to end up in the emergency department and very dissatisfied and in pain. And so don't make bad patient care decisions to satisfy these metrics. That is not the intent of our work. And then I worry about some providers just, washing their hands of the whole thing, getting out of the whole thing. Transfer all your patients away. Maybe it's a good time for an early retirement. Just refuse, because then those patients they don't have a prescriber and they have to go hunting for a new prescriber. And it's harder and harder to find a new opioid prescriber. So don't abandon your patients. But do start thinking about ways that are patient-friendly to adapt your practice and to improve compliance with these measures. Try to strive for the spirit of what we're doing and always be patient-centered. This is an excellent guide for opioid dose reduction in chronic pain patients. This is released by HHS. So if you're thinking, Matt, now's a good time to start tapering my patients. Now is a good time to start thinking about tapering your patients. I agree with you. This is a great guide to help you on that. And this is also another great guide that can help you tapering opioids, and to do it safely. This was a frequently asked question, a document, frequently asked questions for tapering opioids, and it was done by many of our Minnesota specialists. And I was part of this committee, and we debated and discussed how to word it just right, and hopefully it's a helpful document. There's a couple great resources to help you taper your patients in a way that is patient-centered and safe. So what are some tips for adapting your opioid prescribing? Consider the specific indication. You should no longer be giving opioids for pain. Give opioids for a very highly specific indication. If you just force yourself to consider that, it may change your practice. And when you decide to prescribe opioids, do so anticipating a good outcome. Don't prescribe opioids anticipating a bad, worst-case outcome. I got to give you plenty just in case. Say, I'm going to give you enough anticipating a good outcome. Promptly reassess. Most prescriptions, the vast majority of prescriptions, can end within just a couple days. No more than just a few days is needed. And patients who seek more are probably high risk, maybe high risk, or had some kind of rare bad outcome and need a careful assessment. Benzo co-prescribing is challenging. You should minimize it yourself, and then develop a system for communicating with your psychiatric colleagues to minimize it from another partner as well, and talk to your patients about it. And then start thinking about how to do a patient-centered, safe, slow taper. Checking the prescription monitoring program is going to help a lot. Measures 3, 6, and actually 7 as well. It's a good time to relook at your patient materials that you hand out to the patients so that they are informed of this appropriately. And I think it's important to address this not as an individual, but as a group, because you could make your numbers all look good and it ends up worsening the numbers of your colleague who takes over those patients. Pharmacists are great allies in this. They can help you with a lot of different things. Audrey from ICSI always reminds me the dangers in a default. You do want your defaults to be set to compliance, but they should be your maximum default. Your default shouldn't be the every time default. You really should each time individually assess the patient and minimize the opioids, but you should have some kind of alarm go off telling you you have exceeded, you're out of compliance with this prescription. You can still do it because all of our measures allow for some wiggle room. All of our measures allow for special circumstances, but you should at least know when you're exceeding one of the thresholds, or when you're adding to your numerator to exceed a threshold. And for patients that struggle, do a careful assessment, mental health and addiction. So I'm going to see, I think we have enough time. I'm going to try to whiz through a bunch of reports. These are actual reports that my colleagues have given me, so they may be helpful. So first, this is an emergency medicine clinician, and this is an example of someone who's in pretty good compliance. Remember that denominator of measure 1, 727, that's how many Medicaid patients they saw in that 12-month period. And you can see, and then the denominator of measure 2 is how many times they initiated opioids. And you can see that for this emergency medicine provider, they are basically just like their colleagues in all measures, and they're under threshold in all measures. So this is one where you say, you, emergency medicine provider, colleague of mine, are basically doing, on average, what all your colleagues are doing, and there's no alarm bells going off. So carry on, And this is a primary care provider. So this provider, and let me move, okay, this provider is over threshold on measure 2. Which means measure 1 is how frequently he prescribed opioids. Measure 2 is when he prescribes opioids, does he do so in high doses, greater than 100 morphine equivalents a day? And 54% of the time, 53% of the time, he was over 100 morphine equivalents a day. But besides that, he's doing pretty good. So for the measure 2, I asked him, well, when you give opioids, what do you give? He's like, oh, I usually give 15 Percocets. And I'm like, well, here's the deal. 15 Percocets is over 100 morphine equivalents a day. If you change that 15 to a 13, but otherwise leave your decision making the same, you're going to be easily under measure 2, the quality improved. So he's got a very, very simple adaptive change. Change 15 Percocets to 30. This is the nuts and bolts of actually acting on these measures. I mean, it's actually quite simple. Also note that for measure 2, his denominator is 15, which means that 8 out of 15 people got, so he saw 658 people in the 12 months, and 8 of them got a high-dose opioid prescription. If he had given a high-dose opioid prescription for measure 2 to 1 fewer persons, he'd also be under the threshold. So he's very, very close on this. We're talking about 15 total patients in the denominator and 8 patients in the numerator. He's very close to his finish line on this. And then he's also over for measure 5. He's over the threshold. However, his denominator here is 8. So these are the old examples, so we don't have the numerators listed, but if your denominator is 8 and your percentage is 12%, your numerator is 1, I think. So this person's numerator is 1, meaning 1 and only 1 person is on greater than, and so this is a very low risk situation. He's got 658 patients and 1 and only 1 person is on greater than 90 morphine equivalents a day. So he's actually doing pretty well, and all this stuff either is not going to result in a QI project or is going to be very simple to adapt its practice in time between now and 1 year from now. This is an OBGYN provider. I want to be mindful of time. I could keep going like this all day. This is an OBGYN provider, and if you look at this OBGYN provider, you're like, wow, awesome. Each of the measures, remember the top bar is the provider, each of the measures is basically 0. This person had 600 OBGYN patients and prescribed opioids to only 1 time total. So you say, wow, this is great. DHS must be ecstatic over this high-performing OBGYN provider. I'm like, time out. Actually, what type of work leads you to never prescribe opioids? And if I was this person's colleague or this person's supervisor, I would say, of course, this is not going to, the supervisor won't see this report. But if I were the supervisor and I saw this report, I would say, why is it that you saw 600 patients in a surgical subspecialty and only prescribed opioids once? This doesn't trigger any QI thresholds, but as a provider in a system, I just want to make sure, maybe you're in a fertility clinic and that's all it is. But I just want to make sure that you're not under prescribing opioids. Think about that. Similar, family medicine clinician, looks excellent, saw 816 patients and is under QI threshold for every measure. So you're like, okay, this feels good, no QI thresholds for the prescriber. But if I was this person's colleague, I would look at measures 4, 5, and 6 and say, you've seen 816 Medicaid recipients and you have never prescribed chronic opioids. What that probably means is that you're refusing to take care of those patients and you're referring them all to a pain doc or a colleague, and your colleague is over threshold. So all the jeopardy, you're putting the jeopardy on your colleagues, which could or could not be a bad thing. And I would just explore with this provider, why do you have 0? In a family medicine practice, to have 0 chronic pain patients raises an eyebrow. Where are they going? You're referring your patients elsewhere, because something like 20% of the Medicaid population, is on code. Or maybe it's gone down to 15%, but it's still, you have 0. So where are your patients? And they're probably referred elsewhere, creating jeopardy for your colleagues. So again, this is not a QI issue for this provider, but it's a system issue. So this is a nurse practitioner who manages a pain clinic. So she's not the pain subspecialist, pain-trained interventionalist. She's the nurse practitioner, as is very common these days, providing the opioids. So because she's in a pain clinic, her measure 1 looks pretty good because she's not initiating opioids that often. When she does initiate opioids, she's more likely to do so at a higher dose. She's in a pain clinic, so she deals with more serious pain conditions. And when she does initiate opioids, she's likely to continue opioids to chronic opioids. Again, she's in a pain clinic. She deals with chronic painful conditions. Maybe you could argue she's also surrounded by opioids, and she's acclimated to continuing opioids long term. But at least I'm not surprised that her measure 2 and her measure 3 are over threshold, because it's sort of inherent to the work she does. She has 134 chronic pain patients. Of those, just over 12% are on high-dose opioids. So her denominator is 134, and her numerator would have been 12% of that, which is maybe 15 patients. And if you look at the number of chronic pain patients on greater than 90 morphine equivalents, you'd say the denominator is 130, the numerator is 15. She needs to get her numerator down. If she wants to just get below the QI threshold, she needs to get 3 of her chronic pain patients to go from above 90 to below 90. And I believe in a year, she can do that safely without adding anyone else to her numerator. So anyways, this is a chronic pain. She's going to have some work to do, and she's going to have some QI projects, but it can all be done. I know her, and most of the work she does, and the work she does is high quality. And so she's going to be able to navigate this process. And actually, some things like measure 6 looks excellent for her, given that she has 134 chronic pain patients, how few patients she has getting benzos from another prescriber. So she's really high performing in some ways as well. I want to make sure there's enough time for questions. So I know I have some other, I want to show maybe one more. I want to show one more. Well, I want to show 2 more quick ones. This is a dentist. This dentist at Hennepin Healthcare, 70% of his patients, he initiated, they were opioid naive, then they saw him, and then he initiated opioids on. And that is that blows away our threshold. This is the highest number I've seen. 70% of his patients are initiated on opioids. And he's basically and it's almost always low dose opioids, and there's no chronic opioids. So the point is, our dental clinic is very procedurally oriented and deals with a lot of facial trauma. And this general dentist may actually be a surgical dentist. And that may, if he were to get his categorization correct, that may lead to an exemption in measure 1. So just understanding what kind of work this dentist is doing, that he's initiating opioids 70% of the time. I think I'll just tell you, this is another case like I did before. This is a primary care physician's assistant, and he's over threshold in measure 2. In fact, 95% of his initiating opioids is over threshold. And when I asked him, what do you give when you decide to give opioids? What do you give? He says, well, I usually give 60 Percocet is how I start my opioid prescriptions. And so that's a real issue. And so I said, whoa, time out. When you're initiating opioids, your default is to give 60 Percocets on the first prescription. This report is actually really helping us meaningfully engage that provider on changing and adapting his practice. Because I said, that's too many opioids to give on the first bottle. You got to lower it dramatically. So this report really helps us with that. I'm going to stop there, except to say that if you want more technical advice or measures or specifications, you can reach out to DHS, and they can help you get your IT department aligned in how they define these measures with DHS. So I'm going to stop there. Hopefully there's a few minutes for questions. Thank you very much.
Fantastic. Thank you, Charlie. We're going to jump right into questions. And I'm going to let my DHS colleagues respond, and Charlie, maybe you as well.
Sure.
The first question was about kind of whether this only applies to Medicaid patients, and it does, and Minnesota Care members. And DHS, can you explain a little bit more about Minnesota Care members, who that entails?
Sorry, I was on mute. Happy to respond. Really quick, want to just thank Charlie, and I want to thank ICSI for this opportunity. It's been great, and I want to thank you all again for joining. So Minnesota Medical Assistance, is Minnesota's Medicaid program. So that's traditional Medicaid, children, pregnant women, individuals with disabilities, dual eligibles. Minnesota Care is for individuals who have slightly higher income levels, most often single individuals without children, So that is the medical assistance in Minnesota care population. And I believe I'm just going to preempt another question. Someone asked about whether Medicare dual eligibles, so the MSHO and the SNBC population, whether they're included in the reports, and the answer is yes.
Thank you. We're going to go to the next question. It was from a chronic pain provider who doesn't treat much acute pain, but still has patients that qualify for kind of the acute measures, and help them understand if these are truly acute patients or just chronic patients who are just starting opioids. What should that provider do?
Can I take a shot at that? And
Sure.
then maybe DHS? Okay, so this is something I've learned working on many of these committees. The definition of acute versus chronic it's very hard to pin it down. And so we maybe ought not to even use acute pain. What we really mean is an index opioid prescription, meaning the person was not on opioids and then they are. And that could be for an acute pain issue like a broken leg or a surgery, or it could be for a new chronic pain issue like a new diagnosis of serious rheumatologic condition, or a new diagnosis of something, sickle cell disease. A new diagnosis of a chronic pain situation in which you start opioids is an index opioid prescription, even if it's not acute pain. And what we really care about is the index opioid prescriptions, not really the acuity of the pain generator. I hope that's an adequate answer. Someone else could correct me.
And the second part of that question was, does DHS provide a list of the patients so that they can follow up and identify who they are?
I can take this one too if you want. We were talking about this morning. So I think because I'm not DHS, I'm going to say something less diplomatic than maybe they would, which is if you need a list of your own patients that you're prescribing opioids to, that's the spirit of the project. You should have your own list. And this is me, not DHS saying this, but if by the end of this project, every provider in our state has a list of their own opioid patients and they understand the dynamics of each of them, mission accomplished. That's like one of the biggest goals. And so I would say the fact that you're asking for a list is symptomatic of what's happening all over the state. So that's kind of what I would say, but I'll let DHS answer in a more diplomatic or technical manner.
Thanks, Charlie. So I think a couple things in response to that question. Number one, I want to just respond to Dr. Nixdorf's question about the chronic pain provider who has patients showing up in their acute pain measures. And we agree with what Charlie said, and we also recognize that's an issue. So right now we're defining the quality improvement program. I think as we move forward, we'll identify how to address that scenario, but we certainly are aware of that scenario. Regarding the request for patient lists, I would just remind everyone that this data is 3 months old at most. You certainly have patients who you prescribed opioid therapy to a year ago in our data, and that is just the reality of working with administrative claims data, which is where these reports come from. So, we view the reports as a tool to identify where prescribing is going on, but it is challenging for us to give you a list of your current pain patients who you're prescribing to the way that we analyze this data. I would echo Charlie's comment that the patient data is available to you, and I would also remind everyone that this data is available with identified patient information in the prescription monitoring program. That being said, I will say we have had instances where providers certainly disagree or have been concerned that we are erroneously catching a patient, and we can work with you if that's the concern.
I wonder also, DHS, if you could answer, there's a couple of questions about what do they do about providers that still didn't get their reports?
Right, great question, and I want to thank everyone because this is a new process for us too, so we're using these reports as a way to QI ourselves. If you think you should have gotten a report and you didn't, please email the opioid email address, which is dhs.opioid state.mn.us. We are happy to send you an electronic version of your report if you haven't received anything. We also have created a new way to deliver messages about the program through an email listserv, so we will send information about that out after this webinar as well.
And there was a question, will the slide deck be available after the webinar?
I'm fine with that if everybody else is.
Yep.
And one more additional question. What is the plan regarding QI projects when the denominator may be very low? I think this was touched on, but to reiterate.
Right. Charlie touched on it. When the denominator is low, we will have thresholds that if you're under a certain volume, either number of prescriptions or number of patients, you will see that you're flagged for QI, but you will not be expected to participate in the quality improvement project. We really want to work with providers for whom opioid prescribing makes up a significant portion of their practice.
Fantastic. Well, we want to be sensitive to everybody's time. So we know there's a few more questions, and what we'll do is we'll make sure we write this down, and we'll work with DHS to get answers to you all. This was also recorded, so we will get you all that link as well. Reminder, please check out the DHS webpage. They have lots of great information. ICSI and the Minnesota Health Collaborative has been doing a lot of work around opioids, so feel free to reach out to Audrey and myself, and we can share more about that. And with that, I'm going to let everybody go. Thank you to Charlie. Thank you to DHS. We appreciate the opportunity to have you here to share this information, and we hope everybody has a nice afternoon.